you get sick in Canada right now, the question isn't just what's wrong, it's how long will you wait to find out? Months, sometimes longer. And that delay isn't theoretical. It's measurable, documented, and growing. I'm Bo Kaufman, and this is the Sanity Project. Today's episode is a debate, not a deep dive. 2 positions, 1 question. And by the end, a verdict grounded in evidence, not ideology. Canada's healthcare system is under pressure in ways we can no longer ignore. Wait times are climbing, access is collapsing, and provinces are already experimenting with solutions. So where does the evidence actually land? To break it down, I've brought in 2 investigative voices you know well, Alexandra Ives and David Mercer. They're taking opposite sides of one of the most important debates in the country right now, public versus private healthcare. Let's get into it.
Welcome to the deep dive. So today we are taking on a massive, incredibly complex mission.
Yeah, we really are. It's a heavy one today.
It is. We are going to unpack the entire debate surrounding public and private healthcare in Canada, which, is a very charged topic.
Oh, extremely charged. People get very passionate about it, and rightfully so.
Right. And to do this, we are looking at a literal mountain of source material today. I mean, we've got reports from the Canadian Institute for Health Information, the Canadian Medical Association.
We have the Canadian Centre for Policy Alternatives in here, too.
Yeah, the CCPA, plus extensive polling data and even transcripts from televised debates among policy experts. Like, we are going deep into the weeds.
We really are, but I think right up front we need to set the framing for this deep dive.
Yes, absolutely.
Because we're stepping completely outside of politics today. Left-wing, right-wing, ideology, we are leaving all of that at the door.
Exactly. The goal here is not to take a side at all. We are just impartially presenting what the data says. What are the arguments for privatization? What are the arguments against it?
And, what does the international evidence actually show us about how these systems operate on the ground in reality?
Right. Because if you are listening to this and you've ever waited hours in an emergency room, or if you struggle to find a family doctor.
Which is so many people right now.
Oh, it's millions of people. Or if you've ever just wondered why a system that costs roughly $340 billion a year is ranking last among wealthy nations, well, this deep dive is going to explain exactly why that is happening.
Yeah, we're going to map out the entire structural engineering of the system.
So to kick things off, before we can even debate how to fix this system, we kind of have to diagnose it, right? We need to look at the vital signs of where things stand right now.
Right. And according to the sources, those vital signs are, frankly, alarming.
That's putting it mildly. Let's look at the wait times first, because this really sets the stage.
Yeah, so the 2025 data shows the median Canadian wait time for medically necessary treatment.
Just to clarify, medically necessary, so not cosmetic stuff.
Exactly. Surgeries, specialist treatments. The median wait time hit 28.6 weeks.
Oh.
Yeah. Over half a year. But what the data really emphasizes here is that a wait time isn't just a static holding pattern.
What do you mean by that?
Well, the human body doesn't just hit pause while you're waiting for a specialist.
Well, right. Like you get worse.
Exactly. That 28.6 weeks is the time between your GP submitting a referral and you actually getting the treatment. And during that half year, if you have a localized orthopedic issue, like a bad knee,
it degrades into chronic pain.
Right. And then you need stronger medication, which introduces separate pharmacological risks, or, a manageable cardiovascular issue can escalate into an acute event.
So the wait time actually makes the disease worse. It's like compound interest on your illness.
That's a great way to put it. It actively increases the complexity and ultimately the cost of the eventual treatment.
Which is terrifying. And, that assumes you can even get the referral to begin with.
Yeah, that's a whole other bottleneck.
Right, because accessing the entry points of this system, just basic primary care, has become practically impossible for a huge chunk of the population. I mean, look at the emergency rooms.
Yeah, the sources document over 250 emergency room closures across Canada in just the 2024 to 2025 period.
250.
Yeah, which is a localized catastrophe for those communities.
Absolutely.
Because an ER closure is the ultimate downstream failure. It means the local labor pool of trauma nurses and emergency doctors has fallen so low they literally cannot safely keep the doors open.
But the sources say to understand the ER closures, we have to look upstream.
Right, to the foundation, primary care.
And the numbers here from late 2025 are just grim. 5.9 million Canadians have no family doctor.
It's a massive number.
It is, and polling from early 2026 shows that 40% of Canadians either have no doctor at all, or they struggle significantly to access the one they do have.
Right. But, the most fascinating part of this isn't just the raw number of people without a doctor. It's this very specific disconnect that the CIHI report highlights.
Oh, the Canadian Institute for Health Information report?
Yeah.
This blew my mind.
It completely changes how you view the problem. So the 2025 CIHI report notes that 83% of adults actually say they do have a regular healthcare provider.
Right. So on paper, it looks like, hey, the system is working.
Yeah.
83% attachment rate.
Exactly. On paper, it's a highly functioning primary care network. But then you look at the secondary metric. Among that 83% who officially have a doctor, only 27% can actually get an appointment on the same or next day for a non-urgent issue.
Wait, only 27%?
Yeah.
So you have a doctor, but you effectively don't have a doctor when you actually need one.
Right. It's the difference between having a doctor on paper and having functional access to care. And the sources explain that the way clinics schedule and bill actually creates these bottlenecks. Well, a lot of primary care models are built around predictable things, managing chronic diseases, long-term checkups. They just don't have the elasticity to absorb sudden demands, like if you wake up with a severe ear infection.
Right. If I have an infection and my doctor says, I can see you in 12 days, I'm effectively unattached. I don't have a doctor in that moment.
Exactly. So what do?
I go to walk-in clinic. Or, if it's bad enough, I go to the emergency room.
Bingo. And the CIHI data tracks that exact migration. They call them avoidable hospitalizations.
Avoidable hospitalizations. Okay, what does the data say there?
The data shows 325 avoidable hospitalizations per 100,000 people.
Wow.
Yeah. These are admissions for things like uncontrolled asthma or advanced localized infections, things that are totally manageable at a community clinic. But because the clinic was booked up, the patient deteriorates until they literally require a hospital bed.
That is such a huge waste of resources. I mean, we're taking the most expensive resource-heavy infrastructure we have, the acute care hospital, and using it to treat the overflow of a broken primary care network.
It's wild, right?
It's like, I don't know, using a giant industrial crane to do the work of a small forklift, just because the forklift is locked in another warehouse.
That's a perfect analogy.
Which brings us to this massive macroeconomic paradox that the sources spend a lot of time on.
The cost versus outcome paradox.
Right. Let's unpack this. Because Canada spends roughly $340 billion annually on healthcare. We are right near the top of the OECD for per capita spending.
We are funding it at a premium level.
Top dollar.
Yep.
But then you look at the Commonwealth Fund rankings. They rank healthcare performance across wealthy nations. Where did Canada rank?
10th out of 10.
Last place. We are paying for a blockbuster movie and getting a student film.
I mean, where is the disconnect? Is this a failure of funding or a failure of structure? Well, the implication in the sources is that it's a structural failure. If you pump massive amounts of capital into an engine and it produces no horsepower, the flaw is in the design of the engine itself.
So if the structure is failing, we need to look at the blueprint.
Exactly.
And the sources say the first thing we have to do is correct a massive myth about Canadian healthcare.
The pure public myth.
Yes.
Yes.
Because there is this deep cultural assumption that Canada is a 100% publicly funded monolithic healthcare system.
Right, and that assumption just completely masks the reality of how the money works. Canada actually operates on a 70-30 split.
Okay, break that down for us.
So only about 70% of total healthcare spending is publicly financed through taxes. That covers hospitals and physician services. The other 30% is already entirely private.
Wait, 30% of the Canadian system is already private?
Yes, funded through out-of-pocket payments or private employment-based insurance.
And we aren't just talking about, like, Botox and cosmetic surgery here.
No, not at all. We were talking about critical parts of human health. Dentistry, vision care, prescription drugs outside of the hospital, physiotherapy, all of that operates in a private market dynamic right now.
Which has real consequences. The data shows that 35% of Canadians avoid the dentist entirely due to cost.
Right. So a third of the population is rationing their own necessary care based purely on price.
That's a two-tier system already.
It is. The two-tier system isn't some dystopian future. It's the operational reality today for everything outside of a hospital or a family doctor's office.
Okay, so that brings us to the rules of the game. The Canada Health Act of 1984.
Yes, the big one.
Because whenever privatization comes up, politicians always point to the Canada Health Act as this impenetrable wall against private healthcare. But the policy analysis shows that's actually not true.
Not at all. The Canada Health Act, it sets the criteria provinces have to meet to get federal funding. And the core rule is that access to medically necessary hospital and physician services has to be based on medical need, not ability to pay.
Right, so it bans extra billing. A doctor can't charge you out of pocket for an insured service.
Exactly. It bans charging the patient, but, and this is the massive crack in the door, it does not explicitly ban private for-profit companies from delivering those services.
Wait, really?
Yeah. As long as a private company bills the public provincial insurance plan and doesn't charge the patient at the point of service, it is totally legal under the Act.
That is fascinating. So the funding is public, but the delivery can be private.
Exactly. In fact, most family doctors in Canada are essentially independent private contractors. They lease their own office space, hire their own staff, buy their own equipment, and then they just submit an invoice to the provincial government.
So private delivery is already baked into the DNA of the public system.
It is. But the tension happens when the public funding is capped and the wait time stretched to 28 weeks.
Right, at that point, people start looking for alternatives.
And that leads to the biggest legal challenge to the system in Canadian history, the 2005 Chaly v. Quebec Supreme Court decision.
This case is cited everywhere in the source material. It's the pivotal moment. Tell us about George Ziliotis.
So George Ziliotis was a patient in Quebec who had been languishing on a wait list for hip replacement surgery for about a year. He was in severe pain. And he, along with his doctor, Jacques Chaly, brought a constitutional challenge against the province.
What was their argument?
They argued that Quebec's law banning people from buying private health insurance for medically necessary services was unconstitutional. They said, look, if the government enforces a monopoly on healthcare, but then fails to actually deliver care in a reasonable time, you can't legally stop a patient from buying private care to save their own health.
Because the delay itself is endangering them.
Exactly. They argued it violated the Quebec Charter of Human Rights and Freedoms, and the Supreme Court actually agreed with them.
Which is huge.
It was an earthquake in health policy. The court ruled that when public wait times are so long that they increase the risk of mortality and severe pain, blocking private insurance is unconstitutional.
So if the government can't provide the service, they can't legally stop you from buying it elsewhere.
Right. And while the ruling technically only applied to Quebec, the precedent it set altered everything. It showed that the public monopoly is conditional on performance. If performance drops, like, say, a 28-week wait time, the legal defense against privatization crumbles.
Okay, so if the system is strained and the legal door is slightly ajar because of the Chaly decision, it makes sense that provinces are starting to experiment.
They are.
And the most aggressive experiment right now is happening in Alberta. Let's talk about Bill 11.
Yeah, Alberta's 2025 Health Statutes Amendment Act. Bill 11. This is a fundamental rewrite of the rules.
So what exactly does Bill 11 do? Because the sources talk a lot about dual practice.
Right. So dual practice means a doctor is allowed to work in the public hospital system, billing the government, but they are also legally allowed to work in a private for-profit clinic and charge unlimited out-of-pocket fees to patients for those same medically necessary procedures.
Wait. So a surgeon could work mornings at the public hospital and then go across the street in the afternoon and charge someone 10 grand for a knee surgery to skip the line.
Basically, yes. It creates a dual revenue stream for the physician.
Okay, so what is the proponent view here? Why does the Alberta government say this is a good idea?
Well, groups like the Montreal Economic Institute argue that introducing private money expands the total volume of healthcare being delivered. They argue that if a wealthy person voluntarily leaves the public line to pay privately, the public line gets shorter for everyone else.
Mathematically, that sounds logical. You remove a person, the line shrinks.
That's the theory. They also argue it brings Canada closer to top-performing European models, and that it helps retain doctors who might otherwise leave for the US because they can earn uncapped fees in the private tier.
Okay, but the opposition view from the CCPA, Canadian Doctors for Medicare, the Health Coalition, they go hard against this.
Fierce pushback.
Yeah. And their main argument is about cannibalization. Let's explore this because this is where it gets really interesting. If a doctor can make twice as much in a private clinic, what is keeping them in the public hospital?
Exactly. The critics argue that healthcare labor is highly inelastic. We have a finite, strictly capped number of scrub nurses, anesthesiologists, and surgeons in the province.
You can't just magically spawn new nurses out of thin air just because a private clinic opens.
Right. So if a private clinic opens, it has to recruit its staff from somewhere. Where do they get them? From the public hospital across the street. They offer better pay, regular daylight hours, no messy emergency trauma cases.
So the private clinic drains the staff from the public hospital.
Yes. And what happens to the public hospital? It might have empty operating rooms because there are no nurses to staff them. So even if a few wealthy patients leave the public queue actually slows down drastically because the capacity was cannibalized.
So the wait times for everyone left behind actually get worse.
That is the core argument of the opposition. They say this isn't a European model. It's a shift toward a US-style two-tier system where wealth dictates access and the public system just becomes a dumping ground.
Man. Okay, so that's Alberta. But this debate mirrors a huge conversation happening in Ontario right now, too.
Yeah, Ontario is facing a massive crisis with surgical backlogs.
The numbers in the sources are wild. A waitlist of 206,000 patients for surgery in Ontario.
It's a staggering backlog.
And Ontario's proposed solution relies heavily on private, for-profit surgical clinics to clear that list.
Right, and there is a lot of public support for this. An MEI poll showed that 74% of Canadians actually believe private entrepreneurs can deliver services faster than government-managed hospitals.
Which brings us to the focus factory model. We saw this argued heavily in the TVO debate transcripts.
Yeah, the argument for private clinics here focuses on what they call the low-hanging fruit. Routine cataract surgeries, simple hernias, high-volume, low-complexity stuff.
The argument is that major public hospitals actually want this stuff moved out.
Because major hospitals are designed to handle unpredictable chaos, right? They are multidisciplinary trauma centers.
Right, like if you're prepped for a routine hernia surgery and a massive car crash happens on the highway, 5 trauma patients roll in, your hernia surgery is canceled.
Immediately. The staff is diverted to save lives, and you go home and wait another 6 months.
Right, but a private surgical clinic doesn't have an ER. It just does hernias all day, like an assembly line.
Exactly. It's a highly streamlined single-track operation. And the C.D. Howe Institute points out that relaxing regulations to allow this could save Canada billions. Because surgical wait times cost the economy billions in lost productivity. People waiting for new knees can't work.
So streamlining that makes total sense. But, and there's a massive but here, the sources also detail the arguments against these private clinics. And the biggest issue is upselling.
Yeah, the upselling problem is a huge red flag in the source material.
Let's highlight some of the specific anecdotes we read. Because the funding for these routine procedures is capped by the public system, right?
Right. The private clinic gets a set flat fee from the government for, say, a cataract surgery.
But the clinic is a for-profit company. It needs to generate a profit margin for its investors.
And if the government fee is capped, the only way to squeeze out a profit is to generate extra revenue directly from the patient.
Which leads to what the transcripts describe as coercive upselling. A patient goes into a private clinic for a publicly funded cataract surgery. It's supposed to be free. But before the surgery, they are handed a menu of upgrades.
Yeah, like being pressured to pay $2,000 per eye out of pocket for premium artificial lenses.
Or, and this is wild, charging patients $200 for specialized biometric eye measurements.
Right, measurements that the sources note often lack proven medical efficacy over the standard publicly funded tests.
For total conflict of interest, the patient doesn't know if they need the $200 test. They're scared, they are vulnerable, and the person advising them is the exact same corporate entity that profits from selling the test.
It tests the ethical guardrails of medicine, for sure.
And it's not just financial risks. The sources point to the grim reality of quality and safety in for-profit healthcare, specifically looking at the COVID-19 pandemic.
Right. The data on long-term care facilities during the pandemic is devastating.
It really is. The sources show that privately operated for-profit long-term care facilities recorded mortality rates nearly double those of publicly operated ones.
Double the mortality.
Because to extract a profit margin from a fixed public budget, they had to cut costs. And you cut costs by reducing staff, relying on part-time labor, paying lower wages.
And the clinical result of that was catastrophic during a crisis.
And then there was the administrative bloat argument. If we move toward a multi-payer US-style system, we import their inefficiencies.
Oh, the U.S. administrative bloat is legendary. The sources note that 30% of all U.S. healthcare dollars are spent purely on administrative overhead.
30 cents of every dollar just vanishing into billing departments, insurance denials, complex software.
Right. Every dollar spent fighting an insurance claim is a dollar not spent on patient care. Critics argue that introducing private insurance markets in Canada will just replicate that bloat.
Okay, so whenever privatization is proposed, politicians always point to Europe. They say, look at Germany, look at France. But when critics attack it, they point to the US or Australia. So what does the international evidence actually show?
Well, let's look at the European reality first, because as you mentioned, 64% of Canadians support adopting a French or Swedish model.
It sounds so appealing, but the CCPA data really clarifies what that actually entails, because it is not what Alberta is proposing.
Not at all. European systems like Germany and the Netherlands are heavily regulated. Their insurers are often mandated to be nonprofit.
And they have incredibly strict price caps, right?
Exactly. A private clinic in Germany cannot just decide to charge $3,000 for an MRI because they want to. The prices are centrally negotiated and strictly capped.
And the employment structure for doctors is completely different.
This is the key difference. In European systems, hospital specialists are largely salaried employees. They have strict contracts that legally limit their private pay work. They must fulfill their public duties first.
Whereas in Canada, like we discussed, doctors are highly autonomous, fee-for-service independent contractors.
Right. So if you allow Canadian doctors to do dual practice without the strict salaried contracts of Europe, there's nothing stopping them from abandoning the public queue to chase higher fees in the private clinics.
Which ties right back into physician compensation, because European doctors are paid way less than Canadian doctors.
The numbers are stark. An Alberta specialist averages about $427,000 US. In France, it's $115,000 US.
That is a massive gap.
It is, but because they pay doctors less, European systems can afford to hire way more of them per capita.
Right, the density metric.
Yeah. Alberta has 2.4 doctors per 1,000 people. Germany has 4.58.
Nearly double the doctors.
Exactly. So Germany has the operational slack to allow some private delivery without instantly draining their public hospitals. Canada does not have that slack.
So, synthesizing this, borrowing private delivery from Europe without borrowing their strict price caps and their salaried contracts and their lower pay. It's like buying the wings of an airplane but leaving the engine behind and just expecting it to fly.
That is exactly what the CCPA report argues. It's structurally incoherent.
And the expert sources point out that if you want to see the closest model to what Alberta is actually proposing, allowing duplicative private health insurance so people can jump the queue, you shouldn't look at Europe. You have to look at Australia.
Yes. Australia is the ultimate cautionary tale in the source material.
Let's break down the Australian model, because they actually did engineer a parallel private system. They even used public money to subsidize it.
Right. The Australian government spends $7.6 billion a year subsidizing the private health insurance industry.
$7.6 billion to prop up private insurance.
With the exact theory we heard earlier, that if you push people into the private system, it relieves the pressure on the public queue.
Okay, so they spent billions to test the theory. What happened to the wait times?
The empirical data shows it failed. Their public wait times for priority procedures are actually longer than Canada's.
Wait, longer?
Yes. The sources isolate knee replacements as a benchmark. The median wait in Canada is 161 days. In Australia, the median wait is 265 days.
Wow. Even with $7.6 billion in subsidies to the private sector, why did it fail so badly?
Because of risk selection, or what economists call cream skimming.
Cream skimming.
Yeah. Private insurers and clinics design their businesses to attract only the most profitable patients. Young, relatively healthy people who just need simple, standardized elective procedures.
So they skim the low-hanging fruit.
Exactly. But they actively avoid complex, elderly, or multi-morbid patients. They dump all the highly complex, expensive cases entirely onto the public system.
So the public system loses the easy, cheap procedures that help balance their budgets and gets stuck with only the most difficult, resource-heavy patients.
All while competing with the private sector for the exact same limited pool of nurses and doctors.
That is wild. It doesn't act as a pressure release valve at all. It just drains the public system.
Precisely.
Okay, so if the status quo is failing us, and unregulated privatization carries massive risks of upselling and labor drains, what solutions do the sources actually suggest? How do we fix this?
The consensus in the reports points toward evidence-based innovations entirely within the public system, and it starts with completely redesigning primary care.
Right, because the solo family doctor model is obsolete. One doctor trying to manage 1,500 patients just creates the bottlenecks we talked about.
Exactly. So the proposed solution is the patient medical home model.
The team-based approach.
Yeah. Instead of just a doctor, you have a clinic with family doctors, nurse practitioners, pharmacists, social workers all working together.
And this expands the scope of practice.
Right. If you just need routine management of your blood pressure meds, you don't need to take up a 15-minute slot with a doctor. You see the clinical pharmacist.
Which frees up the doctor to handle the complex acute cases. It massively increases the capacity of the clinic without needing to instantly hire 10 new doctors.
It's a huge efficiency game. But, we still do need more personnel overall.
Because the population is aging, demand is going up. We just need more people.
And the sources point to a massive underutilized asset right here in Canada. Foreign-trained medical professionals.
Right. The credentialing bottleneck. We have experienced doctors driving Uber because they can't get through the regulatory red tape to practice here.
Exactly. The system has historically protected its domestic labor monopoly, but the sources say provinces are finally fast-tracking these credentials. 5,000 immigration spaces were recently reserved for healthcare workers.
And there was a really fascinating data point about U.S.-trained doctors, too.
Yeah, 570 U.S.-trained physicians actually moved to Ontario recently.
Which completely flips the narrative. We always hear about the brain drain, doctors leaving for the U.S. to make private money, but over 500 U.S. doctors moved here.
It shows that despite the friction, the Canadian public model remains attractive. You don't have to fight with insurance companies over billing codes all day.
Okay, so we have team-based clinics, expanded scopes, faster credentialing, but to really make this work, the sources say we have to modernize the underlying law.
The Canada Health Act.
Right, because the expert points out it was written in 1984.
Think about medicine in 1984.
I mean, MRIs barely existed.
Exactly. Laparoscopic surgery was in its infancy. The whole idea of an outpatient surgical center where you get a new knee and go home the same day was science fiction.
The entire system was built around the physical building of the general hospital.
Right. And because the act was written for a 1984 reality, it struggles to govern 21st century medicine. Virtual care, community clinics, private MRI facilities, they operate in this regulatory gray zone.
Which is exactly what for-profit companies are exploiting right now with upselling and access fees.
Yeah. So the consensus isn't to scrap the act, but to update it. Federal Health Minister Marjorie Michel is currently reviewing this. The goal is to close the loopholes that allow upselling while bringing new delivery models under the public funding umbrella.
Ensuring that the new technology benefits everyone equally. Not just those who can pay.
Exactly.
Wow. Okay, we have covered a massive amount of ground today.
We really went deep on the structural engineering.
We did. We looked at the undeniable crisis in wait times, the complex reality of the 70-30 funding split, the risks of labor cannibalization and upselling in private clinics, and that crucial context that European systems only work because of heavy regulation, not just free market capitalism.
The Australian example really highlights what happens when you get that wrong.
It really does. So as we wrap up, I want to leave you, listener, with a final provocative thought to ponder based on all this evidence.
Let's hear it.
If the Canada Health Act was written in 1984, before the invention of the MRI, before the internet, before outpatient surgical centers even existed as concepts, how much of our current crisis isn't actually a failure of medicine or a lack of money? How much of it is simply the friction of a 20th century legal framework, trying desperately to govern a 21st century reality?
That is the big question. The architecture has to evolve to match the technology.
It does. Thank you for joining us on this deep dive into the source material. We hope that the next time you see a headline about healthcare reform or a debate over privatization in your province, you question it. Look closely at the data, examine the underlying economic mechanics, and think about how these policies actually impact the reality on the ground.
Thanks for listening.
Until next time.
That was Alexandra Ives and David Mercer. And more importantly, that was the evidence speaking. Because here's the reality. This isn't about picking a side and digging in. It's about fixing a system that, right now, isn't delivering for millions of Canadians. If you found this valuable, go deeper. Head over to thesanity.org for the full breakdown, sources, and weekly analysis that cuts through the noise. And if you want more conversations like this, grounded, direct, and evidence-first, make sure you're following. I'm Bo Kaufman, and this is The Sanity Project.
If you want more facts and less fear, hit subscribe. Check out the next breakdown wherever you're listening or watching. Stay sane, Canada.